This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 92 for November 22nd, 2023. We're calling this one Artificial Intelligence and Machine Learning in Medicine. Want to welcome all of you to the program. So we have a fascinating episode of our CME podcast this week as we take a pretty deep dive into the current and future roles of artificial intelligence and machine learning in healthcare and medicine. But before we get into any of that, I want to pause and wish all of you in my American audience a very happy Thanksgiving, which is tomorrow. And, it's a great opportunity to reflect upon the things that we are grateful for in our lives. And, given recent events from pandemics to natural disasters and intense fighting in the Middle East and Ukraine, there have been and continue to be lots of anxiety-provoking events in our lives and in the news. But it really is a great time to pause, take a deep breath, and count our blessings. For me, that is a fairly easy exercise. I am extremely grateful for my family, my many friends, my medical career, this podcast, and all of you in the PediaCast audience. You are all appreciated, and I'm grateful and thankful for each and every one of you. I truly hope you have a wonderful Thanksgiving shared with family and friends. All right, so let's turn our attention to artificial intelligence and machine learning in medicine. We covered this topic on our podcast for parents. That was also called Artificial Intelligence and Machine Learning in Medicine. It was PediaCast 541. And in that one, we really just scratched the surface of the many uses of AI and machine learning in healthcare and medicine. Today, we're going to take a deeper dive, and we have two excellent returning guests with us. Dr. Laura Rust is an emergency medicine physician, also with clinical informatics at Nationwide Children's Hospital. And Dr. Tyler Gorham is a data scientist at Nationwide Children's. Now, before they join in on the conversation, I have a little secret that I want to share with all of you. As a test case for the role AI and machine learning can play in medical education, I use these technologies extensively in planning for this episode of PediaCast CME. That's something I've never done before, but, I thought I would take it for a spin and see how it turned out. So I did have ChatGPT help me with the interview questions, the learning objectives, the post-test questions and answers, the episode description in the show notes, and much of the research that went into this episode. There was some serious use of artificial intelligence used in the show prep for this episode. Now, of course, the information was vetted and tweaked some to fit my voice and the usual style of our program. But it was a fascinating experience, to be honest. Also, more than a little scary regarding how little I actually needed to change the content my AI friend spit out. But I did have to change some of it and, like I said, make tweaks and vet it and double check some things. And so, it's still great information, but it took me, really less time than it usually does to prepare for a show because of the use of that. So we'll share our little secret with the guests upon the conclusion of our interview. All right, let's cover our usual housekeeping items. Don't forget, you can find PediaCast CME wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. And speaking of that educational credit, it's really easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at pediacastcme.org. You'll find a link to the post-test in the show notes. follow that link to Cloud CME. You'll need to click the materials link and pass the post test, and then the Category 1 credit is yours. It's absolutely free. And we do offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Instagram, Threads, LinkedIn, and Twitter/X. Simply search for PediaCast. And of course, we have that handy contact link if you would like to suggest a topic for a future episode of the program. That's over at PediaCastCME.org. Also want to remind you, the information presented in every episode of our podcast is for general educational purposes only. All right. So also got to add, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. Laura Rust and Dr. Tyler Gorham settled into the studio, and then we will be back to explore artificial intelligence and machine learning in medicine. It's coming up right after this. Dr. Laura Rust is an emergency medicine physician and clinical informatics expert at Nationwide Children's Hospital and an assistant professor of pediatrics and biomedical informatics at The Ohio State University College of Medicine. Dr. Tyler Gorham is a data scientist at Nationwide Children's. He earned his PhD in public health and environmental health sciences from The Ohio State University and now collaborates with other data scientists and clinicians to build machine learning algorithms that predict adverse health events and improve patient care. Both have a passion for using data and technology to improve child health. That's what they're here to talk about, artificial intelligence and machine learning in medicine. But first, let's offer a warm PediaCast welcome to our guests, Dr. Laura Rust and Dr. Tyler Gorham. Thank you both so much for visiting with us today.
Thank you so much for having us.
Yes, thanks.
We get to say thanks for having us back.
Yeah, welcome. Yeah, thanks for welcoming us back.
That is correct. And of course, we appreciate you guys stopping by again. The two of you were on our PediaCast for Parents, where we talked about artificial intelligence and machine learning in medicine. We really talked about it sort of at a large lens, overhead view, kind of superficial. And we're going to definitely dive deeper today as we do this one for providers and offer continuing medical education credit. But I still think a great place to start, Tyler, is what is the difference between artificial intelligence and machine learning? Because, we hear both of those terms, and I think some folks think it's the same thing, but that's not quite the right relationship, correct?
Yeah, you're exactly right. And you've honored the data scientists in the room for acknowledging that. So thank you. Doesn't keep me up at night, but it's good to distinguish between the two. So artificial intelligence is the most broad term that we'll use today. So it's really the umbrella under which these other techniques fall. So it's the ability of a computer to accomplish some task that typically requires human intelligence, things like problem solving, reasoning, planning, decision making, making inferences. So that's kind of the wide umbrella of artificial intelligence. And historically or generally, it can be accomplished in one of two ways. And you can do that through rules-based programming, where I can manually code a set of if-then rules. And if we have enough of those, it starts to look like an intelligent human decision has been made. One example that's been really powerful and well adopted, a team from NCH, not Laura and I, but a team from NCH created this automated sepsis screening tool that has now been integrated into our EHR vendor and is used nationwide. And that's a great example where it's automating a process based on these expert rules, but there's no machine learning in the background. So it looks intelligent, it is intelligent, but there wasn't machine learning in that. Machine learning then is a subset of artificial intelligence. And in 2023, they're almost synonymous, where everything that has hype right now, if you're talking about AI, there's machine learning behind it. So machine learning then is the ability of a computer to have that human-like intelligence without that manual programming where, yes, we have computer code behind it, but it's really just feeding a lot of data into these algorithms, and the machine can learn those patterns in the data, learn those relationships in the data without that manual programming.
Yeah, yeah. So, so to sort of sum that up, machine learning is a type of artificial intelligence.
Yep.
And artificial intelligence is going to just at the plain level is going to follow a program that has been created by humans, and so there's some smartness to it because it is traveling down an yes or no algorithms and coming up with the right answer based on the person who programmed it and their knowledge. Whereas machine learning is each time it goes through an algorithm, it must get some kind of feedback of whether that algorithm was correct or not correct. Maybe that feedback is compared to other algorithms it does.
I'm
trying to make sense of how
right.
a machine can learn.
Yeah, so I like to think of this to other data scientists. I'm sorry, this is the best way that I personally understand it. So this isn't me dumbing it down for anyone but myself. But I like to think of machine learning working much like I did in college, where if you give me enough practice exams, I'll be able to do better on the test when I see questions that I haven't seen before. And so when we talk about training data, it's much like giving the computer these practice exams where there are scenarios that you may learn patterns. You're learning how to think in this specific field or in this certain problem without actually seeing the exact questions that you're going to be asked when you go to apply your knowledge. So it learns from this training data. We identify from labeled data. So each of your examples has whether or not a certain outcome, for example, did this patient go on to develop heart disease, for example? And so we feed that data in and it can learn those relationships from the patient data on, patients that have X, Y, and Z risk factors combined together may be more likely to go on to have heart disease. But I didn't tell them that it's a combination of these features. I just provided that data. So it learned from those training examples.
Okay. Yeah, that makes sense. And then as it's learning, if it comes across examples that didn't match up because it gets some feedback in one way or another, then that new information becomes part of the algorithm moving forward.
For certain algorithm training types, yeah. If it's something like logistic regression, we pass it through once and you're kind of stuck with what you have, sort of like having one practice test. I don't know how to improve if I only have one. But yeah, there's reinforcement learning where within deep learning, which we'll talk about later, things like back propagation, where you can pass that data back through a second time and say, okay, let's tweak the things that we got wrong the first time and see if that improves our performance.
Yeah, that makes sense. Let's actually take a step back because I feel like artificial intelligence and machine learning in the last handful of years, and I think even from like 2019, like during the pandemic, I don't know if there were computer programmers that didn't have other things to do. It just seems like there's been an explosion of this stuff since the pandemic. And maybe that's just an association in time and not cause and effect. But in any case, it's interesting. But we've always used not always, but we've used a lot of artificial intelligence stuff, and even in the past 10 to 20 years. And so why don't we take a look backward? And Laura, what are some of the ways that artificial intelligence has been used in healthcare and medicine sort of historically?
I think you hit the nail on the head. I think, it's really been hyped up in the news recently, but we've been using artificial intelligence in healthcare for decades, like you pointed out. So I think over the years there's been this progression, though, certainly of its complexity and how useful and its predictive power. So it started off pretty early with kind of that rule-based logic, like if this, then do this, in a really simplistic fashion. So an example of this is the automated EKG interpretation, which we've all been taught to trust but verify, or not even trust sometimes, I should say. So for the cardiologist listening, always double check. But that is it in its most simplistic form. Then we kind of moved on to these like risk score calculations. So kind of our automated sepsis screen is kind of a risk score calculation example of that. And then predictive analytics, so getting a little more sophisticated. So we'll talk a little bit later about local examples of that. So our deterioration risk index project being one of those. And then the more sophisticated ones, the machines that quote learn, neural networks, which Tyler will talk about later. And then really this kind of generative AI large language models, which I think is what the hype has all been about recently. So ChatGPT being one example of that. So, and that's a type of deep learning that kind of uses natural language processing and trained on big data and generates really human-like responses a lot of the time. So that's kind of from the provider and healthcare perspective. And then there's also examples from the patient perspective. So looking at wearable devices, the fact that our Apple Watches can detect abnormal heart rhythms and kind of guide you to have that validated by a healthcare professional, or an insulin pump that can help monitor your blood sugar. Those are kind of examples at the front line from a patient standpoint. And then I think, one of the most promising aspects of this with the large language models is that they really are putting this information and access in a very patient-friendly way at their fingertips. So I kind of view this as really Google on steroids, and we're still trying to figure out how to use that. But I think it's going to be transformative to the patient and provider relationship, because they're going to come to us with information that we may not be prepared to digest yet, because we haven't done that same search as them. So I think it's going to be a really interesting time to watch how that transforms.
Yeah, absolutely. Even today, we're using smart sets and, order sets and things to help us practice and to do things more uniformly within a particular healthcare system. I mean, we all know that there's oftentimes more than one way to treat a problem, but we sort of want to be uniform within an institution so that, when people are comparing, like, oh, the doctor told me this, and then someone else like, well, the doctor told me that. And they may both be correct. But when things are done more uniformly, it seems to, you get better patient experience for sure. And then, so we've had these order sets and such. Do you think that there'll be a day when you can have like a Chat GPT sort of system that is more, is definitely evidence-based and has been vetted, and you can just type in like, my patient has this, what should I do?
Mm-hmm. Yep. I think we're already headed that direction. Our EHR vendor is already looking like, how do we integrate with these large language models as a tool? And I think they're very much focused on kind of decreasing initially like the administrative burden of healthcare, as opposed to the diagnosis and like patient management decisions, which obviously are more complex. But I think, we have these order sets to standardize care and best practice alerts that, the goal is to standardize care to improve outcomes, which we've shown time and time again works. So like with our clinical pathways program, we do this work. But I do envision a day where the order set, when you open it up, is tailored to the patient that you are seeing. So it, like with a artificial intelligence mechanism that analyzes the patient's history, their specific labs and their parameters, kind of a personalized or precision type medicine that takes into account the standard of care and best practice, but also gives it a twist and applies it more specifically to the patient you're seeing, which we do internally, right? We do in our minds when we're thinking about how do we apply care to a specific patient. But I think it'll just add an extra level of precision to that care.
Yeah. As we think about, can this replace providers at some point in the future? But I think one of the things that right now, at least, that artificial intelligence and machine learning would lack is what the kid looks like. Because you may have something fire because the heart rate's high, and maybe the kid has a fever and maybe they don't, and you're wondering, is their heart rate high because of the fever, or is it because they're dry? Are they septic? And eyes on the patient, there's really no substitution for that. And other than having a video camera and the computer being able to interpret what a kid looks like, that's going to be more difficult to replicate, correct?
I hope so.
Yeah.
I think, there's something to be said for the intangible aspect of what you're able to have with that human connection with people and really having an assessment. With that being said, I saw a funny comic that said, am I going to be replaced by a robot? And the answer was, no, you're just going to be replaced by someone who knows how to use a robot. So I think it just behooves us to start incorporating this type of education within, undergraduate school, high school, even medical school, and then obviously throughout residency and training, et cetera. And circling back, as people have been practicing for 20 years, to make sure that we know how to use these tools, because if we don't adapt and use them well, then I think we will kind of even more quickly fall behind the times now at the rapid pace that these are unfolding.
Yeah, absolutely. It's kind of like in the early days of the internet and the early days of social media, people are like, oh, that's going to go away. That'll never catch on. And I think, if you think that's true of artificial intelligence and machine learning in medicine, you're not correct. It is just going to continue to
Mhm.
balloon and become part of our lives. And we really need to embrace it because there's no other option,
Right.
really.
It's not going.
Yeah, our team is much more for the term augmented intelligence when we talk about AI. So using these different tools to complement what you all do and what you went to school and you've trained for decades on, right? We just hope to kind of help that.
Yeah, yeah. I love that. And because it's not really artificial. I mean, it's real intelligence, right? You're just sort of replicating how the brain works, but with circuits and wires. So one term that has already been brought up that I want to take a little bit of a deeper look at is deep learning.
Yeah.
So Tyler, what exactly is deep learning and neural networks and that terminology? What is involved there?
Yeah, this is really fun. So with apologies to both deep learning experts and neurologists, I'm going to oversimplify the brain and artificial neural networks because they are related to some degree. I'm sure there are plenty of caveats to the experts, but the main idea of a neural network is similar to our neuroplasticity of the brain. So within the brain, I'll be the least educated on this of anyone listening, but within the brain, right, we have neurons. Those neurons meet at synapses, and you have some action potential required to pass that signal on or to pass that message on within these neurons. And my understanding of neuroplasticity is as we're learning, those pathways can be increased or strengthened, right? Those pathways that are deemed to be useful by the brain can be strengthened. So an artificial neural network is a type of machine learning or an algorithm kind of approach. And even within that, there's plenty of different architectures that researchers will use. But it's based on, it kind of looks like a key driver diagram for those in quality improvement, this kind of web of what we call nodes. Those nodes are similar to synapses in the brain where we pass our training data through. Again, we take this large data set and we can talk about the fact that that can be a whole lot of different things, whether it's images or sound waves. You pass the data through, and depending on the architecture, the neural network basically learns what relationships in your data are useful toward that prediction. So you pass your data all the way through this kind of web of mathematical relationships. And then it goes through something called backpropagation, which is similar to what you were talking about earlier, where the model then learns, okay, was this pathway useful in my prediction? Or if it wasn't, we'll terminate that relationship. We might disconnect those two nodes or decrease the relationship that they have. So it's similar to neuroplasticity in that as you're improving your model performance, those relationships that are found to be useful are increased. I think that's probably as far as we can take the metaphor, but again, it helps me to try to think through how these architectures work.
Yeah, absolutely. No, I think that is really helpful. And at the end of the day, it all still boils down to simple computing concepts. It's just now that we have computers that can take more data at once, whereas like it might have taken a month to come up with an answer, and now it can be done in seconds.
Yeah, you're exactly right. So this artificial neural network, these were proposed in the 40s or something. This is not new technology. And the idea that, like you said, we're data scientists just especially bored during COVID or the past 10 years, like what has caused that difference? It's our computing power. It is in part due to these things like transformer models, these new architectures for deep learning, and just the amount of digital data that we have to pass through these. So our training data sets are just enormous now. So yeah, all of that kind of comes to this confluence where now we're at this kind of precipice where this technology that was thought of decades ago is able to really bear fruit.
And I would imagine, Tyler, that especially sitting where you are and with your lens, you probably have a better appreciation than most of us with the human brain, like just how it is able to do what it does and take all this data and come up with not only an answer, but then use language to express that answer to other people in a way that they can understand. Like it really is amazing.
It's unbelievable. So I'm a dad. My kids are 4 and 6 years old, and so this rise of my own understanding of artificial intelligence is coming as I'm watching my kids develop. And the idea that we are so excited about a chatbot that can learn some approximation of our language while my child is doing that on accident is just unbelievable, right? So yeah, I have more appreciation than ever for human intelligence, certainly.
Yeah, absolutely. Laura, what are some examples then of successful integration of machine learning in improving patient outcomes? Because ultimately, that's what we're all here for, is to help people be healthy, to improve their wellness. So what are some examples of ways that we do that with artificial intelligence and machine learning?
Yeah, we've been fortunate to have already had really great successes with this already, both kind of, outside of NCH and within children's. I think some of the earliest successes in AI use in healthcare and improving outcomes are regards to diagnostic imaging. So using AI tools to evaluate a chest x-ray, for example, for early pneumonia detection, or an MRI for stroke. These are some examples where not only have they improved outcomes, but they're rigorous and have required FDA approval for this, and also have been shown to be reimbursed by insurance companies. So I think they kind of set the stage and the precedent for this of these types of tools being part of our daily use. They've also been used for disease identification and diagnosis. So especially in the rare disease arena, being able to type in kind of a conglomerate of symptoms or physical findings and then pair that together and connect you with people around the world that have these. So our own EHR vendor has something where you connect your data, but privately, that with other sites that use that same vendor across the world. And so you can kind of search to see which patients are like mine, and find them and connect. So I think that type of possibility is really transformative.
As you think about that, then the benefit becomes, as you identify patients that are like you, then you can go back and say, hey, this is what worked, and this is maybe what didn't work. And so we can't say 100% that that's going to work or not work for you as an individual, but we can get closer to it's likely that this is going to work because of the similarity with other cases that we can compare you to.
Yeah, and it may not obviously have that same rigor as a randomized controlled trial, but with these rare diseases and the treatments that you're kind of trialing, you don't have that luxury all the time to have those huge numbers and do a trial. So at least having kind of a hypothesis generator with you to say, okay, I found a patient like me, they tried this medication, these were their outcomes, and making that connection, whereas before you wouldn't have had that. Maybe perhaps in a social media group you might have found it, but that kind of puts it within the electronic health record platform where providers can access it as well.
Yeah. And I feel like hematology, oncology, and the allergy folks in particular have really bought into this. And as we think about chemotherapies that are specific for specific cancers, but then also specific all the data, because, you may have one cancer and the same cancer in another person, but the treatment might be different based on other data, that you're then comparing to other people and things that have worked and haven't worked. And the same thing with allergies and the many, biologically active allergy medication. I'm sure I'm the allergists out there are shaking their head at me right now, but you know what I'm talking about. Like there
Yes.
are specific medicines for specific allergies based on lots of data.
And specifically with, cancer and genomics and certain biomarkers, like being able to tailor that treatment regimen, I think has already been shown to have improved outcomes. The other area that I think is really exciting is with drug discovery and development. So using these AI tools to kind of do 3D protein structure folding to kind of anticipate pharmaceutical drug design as well as drug response, and then also vaccine development. As we've seen even recently, that this type of technology really helps expedite that timeline where it used to take decades, can really shorten that time frame to getting it to the bedside to help a patient.
Yeah, absolutely. In kind of working our way backwards a little bit, we've talked about how artificial intelligence can improve outcomes. What about early disease detection and diagnosis? What are some examples that we're using machine learning to actually make the diagnosis and then formulate our treatment plan after that?
So using a lot of it with, again, another imaging example is they use machine learning to evaluate fundus photos to diagnose diabetic retinopathy in adults. They also have predictive analytics for heart failure, and we talked about the cancer diagnosis and also prognosis. So they'll evaluate both imaging studies like a mammogram, but then also kind of maybe correspond that with a pathology slide. Those are other examples. They can also be used for looking at risk of a medication adherence for a patient. So looking at their own historical data of, how often have they filled the medication, mix that with social determinants of health, and how can we then use that information to intervene to improve access and fight those barriers and make it more easy for them to adhere to their meds and get access. Those are some of kind of the external examples. And then for internally, we use our risk prediction score with sepsis, and then we have our machine learning examples of the deterioration risk index, where we use that to help early detection of a patient that is not doing well within the hospital setting, so that we then have a chance to intervene and prevent a patient being transferred to the ICU and having a code. We are also working on a model to predict and ideally prevent neonatal acute kidney injury. So getting that on the radar, the teams earlier. And then also too, we have a asthma outpatient model where we look at patients that are kind of at risk for using the emergency department over the next year. And so that helps to evaluate, things like their past utilization or social determinants of health. And then how do we get them the resources so that they can see their primary care doctor instead of having to go more emergently to an ED setting. So those are some examples of that.
Yeah, absolutely. Tyler, as we think about this and it continues to grow, what are some ethical implications with using AI and machine learning?
Yeah, how much time do we have?
Yeah.
I just that was a planned joke, so I appreciate your laugh. So I would say Laura and I are both AI optimists on the whole. And so when machine learning algorithms are trained with a great deal of intentionality and insight, and we have the right stakeholders at the table, it's not all bad. But when they're designed flippantly or without the right voices at the table, we can certainly propagate historic biases. So our team likes to say that, machine learning algorithm itself is not racist. If we use race as an example of these inequities, the math itself is not racist, but we can also default too far and say, well, because it's math, because it's machine learning, this model must be unbiased, right? But the important part of this is that the algorithms that we're training today are training on historic data. And so if there's some inequity or bias in the data that I'm using to train my machine learning algorithm, that algorithm will learn those patterns, learn those behaviors, and can then go on to propagate them. So as an example, a 2019 study by Obermeyer in Science, and I love this study. There was an existing commercial algorithm used to identify patients with complex health needs, but the organization or the company used past healthcare costs and utilization to kind of as a proxy for healthcare need, rather than using some metric for disease severity. And what we know is that healthcare access in our country differs by race painting with a very broad brush, right? But we have known inequities in healthcare access where white patients have on the whole, greater access to healthcare. And what does that mean for us? It means that white patients cost more. So if you have greater healthcare, you can use that. If you have greater access, you have greater utilization and greater cost. So what it meant for this algorithm that may not appear biased on the front end is that when you're training toward historic costs, white patients that are equally as sick as their Black counterparts were actually more likely to be recommended for care or treatment because it looked like they were going to quote unquote cost more. I mean, it looked like their disease was more severe. So these authors identified this and then actually helped the company. The company was very open to adjusting that model to fix that. So there are a lot of other great examples, but just as an example, when we're training our models on historically, say, racist data, we can propagate those, unfortunately.
Yeah, that is fascinating, and I'm glad that there are folks thinking about that and showing that it does happen, and how can we correct that so that we have equal access and equal care for everyone. And I would imagine too that just even the availability of AI tools might be different depending on socioeconomic factors.
Yes, yeah, you're exactly right. So my favorite example of this, it's an easy example, I suppose, but say we develop the best algorithm in the world to detect AFib using an Apple Watch. Well, we know that not everyone can afford an Apple Watch. So now I'm doing a great job detecting AFib among those that can afford to wear an Apple Watch. So if we're trying to rely on that for, population health or disease surveillance, we're naturally going to increase bias within that outcome.
Yeah, absolutely. And then what about privacy concerns? So all of this data is on a network, which potentially could be hacked into. And so from an ethical standpoint, I'm sure that there are lots of safe nets in there, to protect
Yeah.
folks' privacy, but it's something that we need to think about.
Yeah, definitely. So all of the machine learning that we're doing at the NCH data science team and anyone else doing this research at a hospital, we're doing that within our own firewall. So that data is as protected as anything else at the hospital, right? So when we're training these models to improve patient care, we're doing that in a very safe way. But for physicians, given our audience today, the main thing to know is to not submit PHI to these chatbots. So the idea that we are asking questions to, say, ChatGPT, if I'm just in my web browser asking it questions, that seems like a pretty fair thing to do. But what I'm really doing there is submitting that data to the owner of that chatbot, the data scientists that are serving that up. And as you were saying earlier, those models are learning from those interactions. These models are so large with billions of parameters that they actually have the ability to memorize the input that they're receiving. So if you say that Tyler, age 32, has this health condition, and what do you think he has? Or go ahead and write a discharge summary for this patient. It may be that when someone else punches in that same prompt or a very similar prompt, that it will go and regurgitate some of the features of what you've sent that model about me. So there's ongoing development at NCH for kind of guidelines of physician use of these AI tools. Some are supported, some are not. But the main punchline for privacy and security for physicians is to never submit PHI to these tools.
Yeah. They're very, very smart. And we don't want to do that. I think we're really trained, like, even in email, make sure
Yes.
that the email is encrypted and that there's, if there's any sensitive data in it. So I think we're trained to think about that. So it's sort of a natural extension to recognize that, if you're on a web browser and talking to OpenAI, that, you probably don't want to share patient information for sure.
Right. Absolutely. But when you get such a convincing answer back, it is tempting, right?
Yes. Yeah, that is true. And some folks may not like that at all. And so then the next question I had from an ethical standpoint is consent. And so, as we think about an individual family, they don't want machine learning as part of their care. I think it's going to happen regardless of whether they want it or not, especially as we move forward. But right now, while it's sort of just being started to use and people are like, I don't know, has there been any talk about consent?
That is such a great question. Right now, our consent is primarily based around that original consent to use patient data in a research setting. And so patients can opt out of their data being used at all for research. And at that point, it wouldn't be used in the machine learning algorithms that we're training. But as far as patient care, I'm not aware of an AI specific consent. And I think about that with our outpatient asthma model that Laura mentioned. That is a tool that is, helping us to identify which patients are at greatest risk of an ED event for asthma. And so I'm thinking, this must be a positive thing that you would want your child to potentially be identified as, we're going to send you to a specialist or increase your step-up therapy, whatever that may be. But it may be that, we have known breaches of trust with research, especially when we talk about, health equity and the ways that healthcare has breached that trust in the past. So we shouldn't be shocked that certain patient groups might feel uncomfortable with that.
Yeah, and that I think really, in my view, the way to sort of solve that is just to be open and talk to people and like, hey,
Absolutely.
here's how we got to this decision, and even though it was recommended by AI, I agree with that, and here's why, and that sort of thing. And I think when we have those open conversations and just let people know we're being as transparent as possible, and all of us have your child's best interests in mind, that's probably the way to address that here, because it's becoming to be used so uniformly and across multiple disciplines that you can just sort of assume that there's a degree of AI being involved in your care.
Yep, absolutely.
Yeah. And so I would think these ethical considerations are certainly one challenge that we need to address when implementing artificial intelligence in healthcare. What are some other challenges that patients and families need to think about?
So I guess patients and families, I'm thinking it is that consent and working with your provider to know if I've been flagged by X, Y, or Z model. Why is that? We tend to feel pretty strongly that our models should be interpretable and not just black boxes, so that maybe they do promote patient engagement and a conversation with the patient. For the physicians and more of a technological aspect, this is me putting on my fake physician informatics hat after years of working with Laura, a proper physician informaticist. But there's a few different things that can help us implement models, and we've kind of learned a lot of these the hard way. But having sufficient model characterization. So as a data scientist, I like certain plot types or statistics about how well this model might work, and it makes sense to me, and it makes sense when I talk to other data scientists. But Laura and our physicians ask very good questions about what does this actually look like for the burden at the bedside? How many patients is this model going to flag? How many of those will be correct? How many of those will be incorrect? So we need to have a really good pulse on how well this model is going to perform. And when it doesn't perform well, what does that look like? Lacking that characterization is going to hurt adoption if we are actually able to get it implemented, and just buy-in upfront, whether or not we even get to the point of implementation. One thing with implementation that our team is another thing we feel very strongly about is implementing our algorithms into existing workflows and interventions. So we could create a perfect algorithm, but if there's no response arm to that algorithm, we've created just a lot of noise and another alert within the system, right? Without actually being able to impact patient care and improve outcomes. So we like to see these implemented into existing interventions where we know the response arm, and often that's already something that exists and kind of has traction within the hospital. So I'm not asking physicians and nurses to do something entirely new. I'm just trying to help identify the right patient population that should be, inserted into that intervention.
Yeah. And from a provider standpoint, those alerts, you can get alert fatigue. And so I think, that's another barrier, is that we just start to ignore things because we trust our clinical judgment and like, oh, I don't need the computer to tell me. But maybe those alerts are just, hey, take a pause. And if you aren't really concerned and you think it's a false alert, then that's fine. But just at least pay attention and put some extra thought into it.
Yeah, I think that point is pivotal. I mean, the computer will never be right 100% of the time. And so you always need that moment of pause to think, does this apply to my patient? And if it does, then you can react in a patient-specific way. And if not, then you can kind of feel better about that I thought about it and dismiss it. But yeah, I think alert fatigue is something we think about all the time. So I'm hopeful that these models will also help us kind of upstream tailor that alert when you do see it, and so decrease that. But then, also having a realization of that transparency aspect Tyler talked about. We want, when someone sees an alert, we want them to understand why. Same thing for the provider, same thing for the patients, knowing how it applies. And I will say this is getting kind of increasing more complicated to do with these more neural network, large language models, to know where all of that came from. A resource that Tyler and I were talking about earlier is with some of these large language models, when you do a query or a prompt search, you can ask it almost in a certain way that it provide references to you for what it's recommending, so that you can contextualize it at the end of the day. But yeah, I think having that transparency with both providers and patients and families will be key to this success.
Yeah, absolutely. We've talked about using AI for the diagnosis of and identification of disease processes, and we've also talked about management and maybe personalized management based on big data and an AI and machine learning. Another use is in reducing medical errors. And what is the potential impact of artificial intelligence on reducing those?
A lot, and depends on which type of medical error. Medical errors that occur at various stages of healthcare delivery, and they can have really serious consequences for patients. I think ever since that old Institute of Medicine report, To Err is Human, we've really focused on that. So looking at medication errors as an example, so you can have, did you prescribe the wrong medication? Was it the wrong dose, or was there an administration error? there's already AI algorithms in place to kind of help scan EHRs for signs that this has occurred. And something that historically we relied on self-reporting for. So if you don't have that kind of patient safety culture like we have here, you may not know what is happening. But kind of upstream of that, we use the system already to help like calculate doses or make those recommendations for based off which indication you are treating. My hope is that, right now we have to kind of reference a drug database or LexiComp we use to say, what is the dose for this disease that I'm treating? I'm hopeful that with tools like AI, as they get more sophisticated, system can suggest that and realize what you're treating. Or if you pick a dose for something, it realizes, hey, on your patient's problem list, it says pneumonia, but you picked a dosing for a UTI. Did you want to update that? I think these are some of the potentials that surrounding medication errors. And then kind of looking at diagnostic errors, right? So if you don't think of a differential diagnosis, then it's not going to be on your list as a potential and for treatment. So you might have a misdiagnosis or delayed diagnosis. These are all things that we're working on within healthcare of how to improve that awareness and take off the blinders that we sometimes get. I think AI is a great tool for kind of putting in symptoms. I mean, I think I remember on my Palm Pilot, I had some type of app as a med student that helped me with this. And there was one of the internal medicine attendings that worked with us said, it's never wrong. It's never not had on the list what it was. So I don't know how true that was for, 2008, but I feel like we've come a really long way of being able to plug in patient characteristics and help you arrive at a diagnosis by at least suggesting things. Because, the human brain, as awesome as it is, it has its limitations, and we can't reasonably process all of the information within an EHR chart for one patient that's been seen at multiple hospitals, had multiple visits and lab values, that we just don't have that capacity to synthesize all of that data. And so I think those tools will, with that type of differential diagnosis.
Yeah. Until Elon Musk gets his way and we have chips implanted to help our brain. No, I jest. Maybe.
Maybe.
We'll see. We'll see what the future holds. Another term that you guys have used that we've not really talked about is natural language processing. Tyler, what exactly is that, and how does that relate to medical care?
Yeah, that's a great question. So natural language processing is applying those artificial neural networks and deep learning that we talked about to language specifically, so to text-based data. So similar to a mathematical problem where maybe we're making some probability of some outcome, this approach is still just learning probabilities and patterns within the data, right? It's not learning formal rules of English. But what's really interesting in making that comparison to how human intelligence works, I was talking to my German friend about this, and the way he learned English was through very specific rules. And if the subject is this, and I, as a native speaker, especially maybe my interest for the English language and grammar, I just learn by ear, right? And so I can't tell you the rules that are there. I just know kind of what sounds right. And natural language processing is kind of picking that up, where it doesn't know the formal rules of language, but it knows what words typically go together. And so it's able to form these incredibly impressive sentences, paragraphs, dissertation level documents or length documents that look a lot like natural human language.
Yeah. And, some of us speak, especially here in the United States, we have such a diversity in our population. And there's a lot of folks who English is their second language. And so when they do use English, it might be in a little bit of a different form. And so the machine has to, I would think, eventually recognize that.
Yeah, there must be some aspect of that. As with many other tools, the model's going to perform best on whatever type of data it had the most training examples for. And so because much of the internet is in English, or the teams, studying this for commercial interest are training these tools in English first, so that that has more commercial viability, say. So there's less. I know this isn't quite the same question, but there's less application or slower adoption or slower results with languages other than English. But I imagine, syntax and dialects add further complication to this.
Yeah. Do you see a time in the future when we really are, and I know that hospitals have to figure out what are their policies going to be, what are the rules going to be, how do we protect patient privacy, all of those things. But one of the things that as we compare today's electronic medical record to when I trained and we had paper charts, it takes longer to see an individual patient when you think about using the computer, which obviously it has so many advantages. But one disadvantage is it really often makes us take more time before we can move on to another patient, or we've seen all our patients and we've waited to write our notes and then we don't remember everything. And so it's, the documentation may not be as accurate. Is there a day when we will be able to push a button and it'll write the note for us?
I think we're getting pretty close to that. And if you asked me that 3 years ago, I'd say, oh yeah, maybe in 20 years or something. But the way these large language models have exploded over the past just 2 years, even since say ChatGPT onward, is just absolutely unbelievable. So yeah, one example, you can kind of think of it as a digital scribe that's recording that patient interaction and then creating your note based on the conversation that you had. So we already have voice to text as the front end of that's receiving those sound waves, and then natural language processing, this large language model that can then transcribe not just the specific verbatim the conversation that you've had, but just give me the bullet points of this conversation. Were different medications recommended? Were different behaviors or patterns identified for the patient? What symptoms do they have? So we're definitely on our way to that, which is absolutely remarkable. A lot of what excites me about data science is extracting value out of the electronic health record. If you all have already been burdened by having to insert all this data, I love the idea of now using this science to decrease that burden and to get you back to being able to focus on the patients.
Yeah, I mean, it really will, especially in my career, feel like it's come full circle when that happens.
Yeah, exactly.
Because paper charts, I mean, you could move patients, and that decreases waiting time, patient satisfaction, because you really feel like you can devote more time to sitting down and explaining things to families, because I knew that I could document very quickly with a paper chart. And now you just feel kind of rushed to educate in the exam room because you've got a waiting room full of people and it's going to take you time to write your note and to justify, your decision-making process. And so I really think that's got to be the next step in terms of making all of our jobs easier. And I think that in turn will improve patient satisfaction because we'll be able to spend more time with our patients.
Yeah, Laura and I just saw an example. Laura, do you want to give the example of using natural language processing for just your inbox and your messaging to patients?
Yeah, I think that I agree with Mike. I think that some of the early promise of this is getting medicine back to what it was. So decreasing that administrative burden where you won't even have to push the button to generate your note. It's just listening in the room at all times. And so not only will it use that to, detail the visit. And so then when you go back to write later, maybe later that night, you're not remembering, was it 2 days or 3 days of runny nose? I don't remember. I've seen 10 of these patients. It's already done that work for you. Yeah. And then on the flip side of that, the patient education aspect. So being able to maybe say out loud a reference point and maybe having that auto added to patient instructions or a certain video reference for them. And like we talked about before, having it perhaps in their native language in a quicker format. I think that, to me, that is the promise of the early stages to get certainly buy-in, right, from clinicians if you can decrease their administrative burden. The other early examples, which some sites are already practicing, is in-basket responses. So auto-generated in-basket responses, which still, they don't auto-send, they auto-generate and then allow you to review it. And then, most provide some transparency that this was made with the assistance of AI at the bottom. But they've done several studies on this, actually comparing provider responses that we've written, which, we unfortunately are limited by time, as you mentioned, and the computer is not. And so providers and patients and families judge the response of a provider versus an AI tool. And the AI tool was deemed to be, more empathetic and sometimes a little more accurate because it had the time, time relatively, could do it very quickly to write that response. And so, the joke is if someone meets you in person and you don't deliver up to that same level of empathy, will they be disappointed? But, these machines they're already that sophisticated where you can use it as a starting point to save time. And then be at the bedside more or having those
Yeah.
conversations.
Yeah. We are really going to have to step up our training for medical learners, empathy and emotional intelligence when those can be programmed into a machine. And the machine has more emotional intelligence than the human provider. So I think from that standpoint, it is, would be meaningful to teach those things to medical students.
Yeah, if you think of a tool like, I think it's Grammarly, you've probably received ads for, right? That will help you, tweak the language that you're using to be more bold or more confident. You can imagine very easily that you could see that almost like spell check for empathy, right?
Yeah, absolutely. And actually, as we talk about that, we've sort of considered limitations to the use of artificial intelligence and machine learning, and actually, we've even talked about limitations to human providers.
Yeah.
Laura, what are some other limitations to the use of artificial intelligence?
Yeah, I think we're still learning a lot about how to use this responsibly and knowing what those limitations are. I think, each hospital system and the government is all trying to write kind of policies around like awareness and safe use. And so I think the one that sticks out to me the most, especially with use of large language models, is that what Tyler mentioned earlier, the data quality and bias aspect of that. So I think people see AI as being more objective and not realizing that the model is trained on our existing biases. There was a Pew Research Center study that showed that racial disparities already exist in the models that we have within ChatGPT too. So how do we not widen that gap of information access? And then also, I feel like patients should not be facing discrimination by our algorithms. So I think that needs to be those equity assessments baked into the part of the system design up front and knowing that awareness. So over time, hopefully, we can take out some of these inequities from our data and then rely on our models. But I think you need to have that awareness that they're already there. And we need to share that with our patients too, as much as we understand it. So I think having a healthy skepticism when you use these to make sure knowing what it's trained on, being able to have it be interpretable and explainable. If you have that kind of what we call a black box model where you don't know why it's alerting on your patient or giving you a recommendation, I think is a limitation and risk. Regulatory compliance. So healthcare is highly regulated. And even though technology is moving at a very fast pace, healthcare traditionally has moved slowly. So I think, while our patients may be using this technology at a pace that we are not able to in a responsible way, I think that will also be a limitation that they may come to us with something where we're not able to use that same tool because of regulatory reasons. And then, lack of standardization, we don't have standardized data formats in all of our hospital systems or EHRs. And so when we develop something based off data locally, that's going to look different than when done at a different hospital. So having that awareness if you're using a model developed on data that maybe doesn't apply to your patient population. So I think those are some of the few examples of the limitations, and I think we'll probably learn more kind of about like what best practice for that is. I know at least our own hospital is working on guidelines surrounding that so we can use it responsibly with kind of, 4 caveats. I think, use it as a supplementary tool. Don't use it to be your only decision maker, which, hopefully people don't do that blindly with our existing decision support things. You should always be thinking if this applies to your patient. And then making sure that we're maintaining patient privacy and training and awareness for it. So work in progress for us as we look to incorporate more of these sophisticated AI tools in our healthcare workflows, but exciting time to be a part of it at least.
Yeah, absolutely. And I like that you said you really do have to consider everything as a human provider and not just take what AI and machine learning is telling you to do. And we're, without thinking about it. And we already do that on so many levels. I mean, when we look at vital signs, we get, something will show up in red with an exclamation point next to it. Or if lab values fall out of the reference range, it lights up red and bold, and we do that now. We look at that and we say, okay, something is warning me, and that's, I guess, an example of really simple artificial intelligence that has been used for a very long time. 30 years ago when I was training, it was available. And so we're used to evaluating whether that's really significant or not significant. And we have to do the same thing when AI spits out suggestions and things. So this has been just a fascinating conversation. And I'm sure that if we had the same conversation 5 years from now, it would be very different. And I think it's exciting to see where all of this is going to go for sure. I want to thank both of you for stopping by and visiting us today. I do have a secret that I want to reveal that the audience already knows because we talked about it in the introduction to this program. And that is, for the very first time ever, I used, because I wanted to see, what could be. And I used ChatGPT to prepare for this particular episode. And so it wrote the learning objectives, the post test, the interview questions, the bullet points for the answers. Like, it did everything. Now, I made adjustments. I took a pause. And one thing I did, though, was I left all the questions in and sent those to you. And I had to keep myself from reacting to it. When we first got online, before we started recording, Tyler said, a lot of this is redundant, and we're talking about things that we've already talked about. There'll be questions later on that we probably already discussed, and he wanted to know if I would probably just skip over some of those questions, and that's exactly what happened. But I wanted to leave it in there just to see organically where this would all go. And I will say it really sped up my prep time. I did have to take that pause to make sure, and I would have edited those questions a little more if I was using it as a tool, but I really wanted to make a point. And so the learning objectives and the post-test questions, you can thank AI and machine learning for those.
Well, Dr. Mike, you're not the only one with the surprise then. Laura and I laughed about inserting some of these questions into ChatGPT ourselves to see, just to see what kicks back. I told Laura, I genuinely use that tool similar to Wikipedia, where I'm not taking everything at face value, but it's a great place to start your search or to start, drilling down what examples does it provide. Maybe we could have just had the robot talk to itself. Have my robot talk to your robot, and we'll skip the next episode. Yeah.
When I did it, I even said, please write 14 interview questions for a podcast for continuing medical education on AI and machine learning in the style of PediaCast. And so I was able to get very specific and give it some instructions on sort of what I wanted it to look like. And I know that PediaCast was sort of in ChatGPT because I don't know if this is a verb yet. I've ChatGPT'd PediaCast, and it comes back with like stuff I forgot.
You have years of training data that you've provided this. Yeah.
Yes, that's right. Yeah. So it did a great job coming up with, other than the redundancy of coming up with the interview questions. So that was a lot of fun, and probably something that I'll continue to use in the future, but, in a very thoughtful and intentional way. And just, it's a tool, certainly not a substitution.
Yeah, there are AI tools where you can even submit your voice and a picture of yourself, and it will generate a response in your voice, or using a video of you as well, as I think we've seen in other examples too. But it's
which is great in terms of if people have great intentions, and then there's also evil that can be used with that same thing. So it's just the world today compared to not that long ago has just really changed, and is changing, and will continue to change. And we're on the ride, so we'll see where it all goes. We're going to have tons of information for you in the show notes, like we usually do, over at PediaCastCME.org. We have a link to clinical informatics at Nationwide Children's Hospital. If you are a provider and interested in getting involved in clinical informatics, we have a fellowship at Nationwide Children's Hospital that you can do and learn more about clinical informatics and become certified and all of that. And we'll put a link to that program in the show notes as well. Also, the podcast that I had talked about that's aimed at parents and families, that's PediaCast 541. And Laura and Tyler were also guests on that one. And so if your patients have questions about artificial intelligence or machine learning, feel free to direct them over to PediaCast 541. And I'll put a link to that in the show notes over at PediaCast CME as well. So once again, Dr. Laura Rust with emergency medicine and clinical informatics at Nationwide Children's Hospital, and Dr. Tyler Gorham, data scientist at Nationwide Children's. Thank you both so much for stopping by today.
Thanks again for having us.
Yeah, thank you. This was fun.
We are back with just enough time to say thanks to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thank you to our guests this week, Dr. Laura Rust, emergency medicine physician and clinical informaticist with Nationwide Children's Hospital, and Dr. Tyler Gorham, data scientist at Nationwide Children's. Don't forget, you can find us wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive there, along with show notes for each of the episodes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, LinkedIn, and Twitter/X. Simply search for PediaCast. So you have listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. Really easy to do. Simply head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. You do have to click on the materials link to find that post-test once you're at Cloud CME. But it's really easy, and again, we do offer credit to many pediatric professionals, and it is free, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you want to be sure the content of the episode matches your scope of practice, which this particular episode really does match everyone's scope of practice. Complete details are available at PediaCastCME.org. We also have a evidence-based podcast for moms and dads called PediaCast, just plain PediaCast without the CME. Lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that episode, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.